It is my honor to give you welcome here tonight. We're delighted by your presence and for you to take the time from your busy schedules to join us this evening. This is a very important moment for Mediphacos and for the corneal surgeon community, because today we have the opportunity to bring together key experts in keratoconus from all over the world who will share their experience and the latest trends in the treatment of keratoconus and irregular corneas. So before we start, I would like to take a moment to thank our program directors and acknowledge their contribution to tonight's program. So Dr. Maria Clara Arbales from Muscat, Oman, Dr. Roberto Zaldivar from Mendoza, Argentina, Professor Jorge Alio from Alicante, Spain, who will be joining us shortly, and Dr. Haikel Kamoun from Tunisia, who is also assisting us in the moderation tonight. We have small changes in the program. One of them is that the keynote speaker, Professor Seiler, is being represented by Michael Mrochen, who will present his paper. And otherwise, welcome again. I hope you enjoyed the program. And please help us to improve the quality of our future meetings by filling out the evaluation form that you will find inside your program. And you can leave it with any of the ESCRS stuff as you leave the room. Thank you very much, and we hope you enjoyed tonight's program.
Thank you. Good evening. Is it working? Yeah. We are going to start the meeting now. The first speaker is from Total Keratoconus Solution, was Michael Rochen. He's going to speak about optimized beam profile for corneal cross-linking.
Good evening. First of all, I would like to thank Marcelo, Alexander, to inviting Theo, not me. Unfortunately, couldn't make it, so I hope you appreciate at least I have longer hairs than Theo. And I would like to check the chairman's. Now, the presentation I'm going to give you is more clinical oriented in terms of optimizing the cross-linking light intensity profile. And before I start, we need to think a little bit more different if we talk about keratoconus and cross-linking. There's a lot of discussion out there, shorter treatment times, save the time of the surgeon. I think from my perspective and from our perspective is we need to get an effective treatment. It must be effective and safe, and this is what we're talking about. And let me guide you a little bit through our thought process and to our results we have when we can change the light profile of the illumination system to improve the efficacy of the treatment. So we're not going to talk too much about time here. We're talking about real outcomes, and we're talking about optimizing the outcomes for our patients. Now, what is the situation? For example, in a PMD, we do have the irregularities of the cornea, and we have a thinnest point that might be here, and we do have a steepest point. At which point would you do a cross-linking treatment? At the steepest point or the thinnest point? Now, if we follow a little bit the work from Renato Ambrosio on looking on the thickness profile in keratoconus, we have seen that in a keratoconic eye, the thickness profile is quite different to a normal eye. We have the thinnest point in the center, and towards the periphery it gets thicker. And actually at a diameter of about 6 millimeter, a keratoconic cornea has a similar diameter than a normal cornea. And that means we need to deal and think about a little bit different in those keratoconic eyes. And to get a maximum stiffness effect, we have to account the thickness profile to get a maximum of volume that we can cross-link to make these corneas more stiffer. And on the other hand, we need to think where to place the treatment. So is the center of the pupil the right position? I don't think so. I think we need to think about the thinnest point as a center of the treatment. How much is this center dislocated? We looked on a range of keratoconus patients, keratoconus, PMD. Actually, there's not too much difference, except that if you look at on the thinnest pachymetry versus the radial distance from the apex, you can see that there's quite a distance between the thinnest point and the apex. So the apex is not really a reference. We need to think about the thinnest point. So in the majority of the keratoconus cases, the weakest point of the cornea that needs cross-linking the most is about 1 to 3 millimeters away from the center. And that's where we need to get the effect. Now, historically speaking, if you have done treatments in the past with a cross-linking device, we have observed that the most effect we get is more or less in the center of the apex, because that's where we center our treatment, and that's where most of the illumination was applied. However, at the thinnest point, more or less over there, you can see at the demarcation line, the treatment area gets thinner. And over the thinnest point, we have practically not really an effect. So the light application towards the specific cornea is of relevance. So this is the demarcation line, and as you can see out here, we're just cross-linking maybe about 150 microns, where here we have about 300 microns of cross-linking. So if you look at the OCTs of 10 eyes, there's an homogeneity in the beam and the curvature, and there's a difference between the amount of cross-linking in the center versus the periphery. And if you do some calculations, you identify that we get about 25% less cross-linking in the periphery. That means 25% less light intensity in the periphery. And that's over a radial distance of about 3 millimeters, which accounts pretty much to what Renato Ambrosio has told. We're getting in the range where we get the weakest point, we're getting less cross-linking in the periphery. So in order to create a homogeneous cross-linking effect, we have to change from a top hat profile, from a constant illumination over the cornea, we have to change that and do more cross-linking in the periphery. So 3 millimeters away from the center, the light intensity needs to be increased by about 25%. So how does this look like? That was actually the initial cross-linking system that we brought into the market in 2007. We had a kind of a pretty much Gaussian-like profile. We believe that adding more light intensity, see here, increasing the intensity in the periphery at about here 8 millimeters in diameter, 6 millimeters in diameter, getting more cross-linking in the periphery over the thinnest point here, we have kept at the same intensity. This will improve the outcomes. Compared to other systems which have more a constant system, we're doing about 25 to 30% more cross-linking. How does this look like? So this is again the demarcation time line measured with the OCT. So here it's about 300 microns, here it's about 300 microns. So we're getting a kind of very homogeneous thickness layer we are cross-linking over the cornea. We did a study in Zurich. Well, Professor Seiler did a study, to be honest. He did the regular keratoconus, no scars, no pre-operation. Standard indication for cross-linking. So progression was shown in those patients. The age was below 35 years. And the best corrected visual acuity was below 25. 36 patients completed now 12-month follow-up. That's about enrollment rate of 95%. To give you an example, a 3-year-old male with progression in the steepening of 3 diopter of 1 year with a thin cornea, 400 microns. Best corrected visual acuity was 0.25. And 12 months we observed a significant flattening of about 6 diopters. And the best corrected visual acuity went back to pretty good functional vision of about 0.7, 20/30. That's his topography. Here's the thinnest point. Again, the demarcation line. Oops, sorry. Demarcation line. Pretty homogeneous cross-linking at 1 month. This is a comparison of the topography. Look, the steepest point here, 55 diopters, down to about 52 diopters. Difference maps, so at around 6 diopter flattening within the pupil. And that explains the improvement in visual acuity. So looking on the data, what we observed is about 95% received a flattening of 1 diopter or more, and a flattening rate of about 2 diopter or more, that's 65%. That's much more than what you have ever seen before in standard cross-linking. In the periphery, the effect was always similar to central, so we're really getting kind of a homogeneous cross-linking profile in depth. complications, the things that are observed, is what you know from standard cross-linking procedures. So in conclusion, we believe the second-generation cross-linking devices need to have a better understanding on the conditions of a keratoconic eye. It needs to adjust the light profile. We believe, of course, we can do things faster. However, we are focusing on effectiveness, and what we found is 10 milliwatt per centimeter squared is extremely effective compared to other experiments we did. And finally, based on the data we have seen so far, we believe, and we're getting more data from Arthur Cummings and from Dresden, we believe keratoconus now needs to be done in every keratoconus patient. Thank you very much for your interest.
Okay. Maria Clara, we have 1 minute. Do you want to ask any question?
Yes, I have a question. Regarding the demarcation line, your aim is to go deep 300 or more, as you see. Do you have data that document that this is the right quantity, or if we do less, we have similar effects?
It's a good question whether if there's a thinner layer that we get a similar effect. And I would like to refer to great work from Gregor Wollensack, who looked on if you only do 100 micron cross-linking, he showed that the biomechanical stiffness effect was not statistically significant to a control. So if you do a more shallow cross-linking, the biomechanical effect is not there.
But stability, how long we are checking in this? Because maybe the biomechanical effect is minimal, but if you achieve stability, we don't need more. And I think this is a question that we all have to ask.
I understand you, man. What your kind of claim is we do less cross-linking, you might get a stability. I think from the data we have seen here, I would change the paradigm of cross-linking in terms of not only making it stable and making it better compared to before, flattening the cornea, improving the outcome in terms of reducing the cone.
I'm totally agreed with making it better, but I have the feeling, it's a clinical feeling, I don't have the research data in this, that we are doing too much.
Too much in what sense? In terms of haze?
Too deep.
Cornea?
No, too deep.
So what is your concern on that?
The change in the refractive power, because I think it's ideal to do cross-linking with no refractive change, to be able to manipulate with the laser.
Oh, we didn't manipulate with the laser. It was just
To be
pure,
be able. I know said you did, but to be able.
If you're talking about LASIK extra, but then I think we should not talk about keratoconus patients.
No, I'm talking about keratoconus patients.
For LASIK extra?
No.
Okay.
Okay, Maria. Then, thank you. Instead, you can explain during your talk also what is your feeling about this. Thank you very much, Michael. The next speaker is going to be Minoru Tomita, that is here. And he's going to speak about OCT-guided femtosecond laser corneal ring surgery. And Minoru is one of the busiest surgeons in the world that you have to appreciate. This probably, I operate a lot, but in relation with Minoru, it's nothing. That he operates is one of the, I think he's the busiest in the world.
Thank you very much, Dr. Salzberg. So kind introductions. I also using the ESCRS systems. So 45 milliwatt with 2 minutes and 45 seconds with 45 milliwatt. But I'm getting almost same result as conventional cross-linking. So but he said that we have to think about it's a rapid cross-linking. But from my experience, I'm getting the same result from the conventional cross-linking. So it's today's topic. So I want to talk about OCT-guided femtosecond laser corneal ring surgeries. So I want to introduce my centers. We are doing we already done over 1 million cases of LASIK. So it's also we have 5 branch in Japan, over 100 doctors. We also doing over 3,000 cases of LASIK extra every month. So we get many hours, and also we have a lot of femtosecond laser and excimer laser too. Yeah. So we also doing all kind of refractive surgeries in our center.
I
So
told you,
it's-
you see, you got to listen.
We started Keraring from 6 years ago. So if we do the refractive surgery a lot, we have sometimes we found the ectasia patients. Even we carefully decide the patients. It's our ectasia rate is very low. Only the one patient from the 20,000 patients. It's very low rate because we deeply examined a lot of examinations before surgeries. So Zimmer's, I'm changed to the femtosecond lasers. Zimmer has Zimmer develops a new Z4, Z6 system. Previously, Zimmer didn't have any vertical cuts, but right now they made it a vertical cut. Then Z6 can make a corneal pockets, same as interest, any place. So you can see video here. If we want to make only one pocket, we can make only one pocket on any place, any size. We can make a pocket with a Zimmer Z6 system. So one complication, ESCRS. So it's we focus the endothelial cell perforations. Rate is 0.6% from the literatures. Then another literature shows endothelial perforation rate is 1.7%. So this is our video with interest. So if we are pronated, so we stop. You can see here we found bubbles. We found tunnel was perforated to the anterior chamber. Then we stopped the surgery at that time. So to avoid the endothelial perforations, if the surgeon is able to visually confirm the depth of the tunnel before the laser operations, endothelial perforation can be prevented. OCT-guided equipment, only the prototype now. The new Zimmer Z6, we are able to have the new OCT technologies. Surgeon can now visually confirm the depth just before the laser operations. This technology brings the greater safety to the ICL channel creations. So you can see here, we have an OCT system here. So we can see the green light here is planned tunnel's place, so surgeon can confirm the endothelial cell layers of the applanated corneas. So this is a plant. So we can see that we have a plant here. Also, we can see the endothelial layers here, and from the two places, horizontal scan and vertical scans. So you can see here. So we can confirm this layer is not perforated to the endothelial cell layers before the operation. So during the tunnel creation, bubble were performed as the laser operations. After cutting, we can see bubbles like this. Before cutting, we confirm. Then after cutting, we can see the bubbles the same place as plant place. So this video shows the ESCRS insertion by using the after creating a pocket by Z6. This is my surgeries. Maybe this is very poor surgery compared to the Francisco Sanchez. So it's very easy to insert it in the corneal ring. So I want to share my experience using my Z6 system. So this is a preoperative, it's data from the patients. One patient is Keratoconus patient, another patient is ectasia patients. So it's uncorrected distance visual acuity is improved almost same. This is even preoperatively it's at 1.0. It's good visions. After 1 day drill down, and the 1 week is come back. For ectasia patients in the uncorrected distance visual acuity was improved 0.15 to the 0.6 at 1 week. And the corrected distance visual acuity was in the Keratoconus patient is almost same to keep the 1.5 in 1 week. And ectasia patient is improved from the 0.7 to 0.9. This is topographies. So we use a Keraring SI5's 160-200 inferior temporal. We can see how it's improved. So it's the lower right improved by minus 5.3 diopter. And this picture shows for ectasia patient Keraring, we use a SI5 160-200 inferior. This patient also improves a lot. So discussion, 100% of endocellular layer perforation can be prevented by visual confirm using OCT-guided application Z6 before the laser ablation. Thank you very much.
Maria Clara? Thank you. Thank you. We are going to ask a question every 2 or 3 paper. Minoru, no, we are going to do the question later. Thank you. Next speaker is going to be Maria Clara Arbeláez. He's going to speak a manager of keratoconus with FEN to assist Keraring and sequential high energy accelerate cross-linking. Maria Clara?
Okay, thank you very much. I'm very pleased to be here. Like always, we have a very good experience using the rings. And I'm confessed that I was one of the persons that was more afraid to do ablations over patients with keratoconus. But here I am doing it. Now, the purpose of this study is to determine the safety and the efficacy of in patients with early keratoconus undergoing simultaneous LASIK and accelerated cross-linking in patients that already have intracorneal rings. We think that combined corneal cross-linking and surface ablations are a viable option to enhance vision in eyes that were previously treated with intracorneal rings and stabilize the ectasia and improve visual acuity with reducing astigmatism and some symptoms we have with the rings. Okay, how we did it? We did not LASIK extra. We did LASIK. We removed the epithelium, and after doing the treatment with a soaking time of 60 seconds, and with the UV radiation of 75 seconds with the intensity of 30 millivolts. All the patients have at least 1 year of the rings previously. Okay, we have 6 eyes for 5 patients. All were got keratoconus, as I mentioned, at least 1 year treated. And we used ablations with the Schwindamari 750, all were customized ablations. And we use, as I said, accelerated cross-linking with the Avedro system. We have only 3 months follow-up in these patients, and we measure all variables, vision, keratometry, topography, and Chimplon imaging. And we are starting to do the measurements of confocal microscopy in some cases, but I don't have it in this presentation. Okay, for the operation, as I mentioned, we use customized profiles. We do the 6D eye tracker and the cyclotorsion, all the capabilities of the laser. And we have ablations between 13 microns to 74, the maximal. We have residual stromal beds between 312 and 445. We can see from the population with the age was around 25. 34, sorry. We have keratoconus stage 1 and 3, and we have, as I mentioned, 6 eyes of 5 patients. Okay, we can see, this is very interesting, the under-correction visual acuity, it was previous the ring, 0.16. After the ring, we improved to 0.31, and after the treatment with the LASIK extra immediate of 0.78, when it's clear the improvement. The best corrected visual acuity was as well improved from 0.61, 0.75 to 0.84. The sphere was reduced to very minimal numbers, and the most interesting is the cylinder, that we start with 365. We have a patient with very high cylinders, to 192, and we go to minimal level. We can see here the keratometries with the same situation. Now we go from one case. It is a very interesting case. We have see a refraction of -5 with -6 with cycloplegia similar refraction with the central pachymetry of 462. We plan two rings, 160, 200, 160, 300. We use all the surgeries with the LDV femtosecond. Here is what we plan, the graph of how we have the plan for the surgery. Now, 2 years post the intracorneal rings, we can see our results. We plan a treatment for a corneal wave front with the refraction of -2, -175. The patient already improved the visual acuity, but still need correction, and we target for plano. We did an optical zone of 6, an ablation depth was 59 in this patient, and residual stromal was 45. Now, the results that we have, excellent. Uncorrected visual acuity 0.8, best corrected 1, sphere 125, cylinder minimal. Improve in all the parameters. We can see 2 years after the ring and after our treatment. This is the differential map of this case. Now we have another case. It's a 20-year-old male, stage 2 of keratoconus, a refraction, less, 2.5 of sphere, 2 of cylinder, with a good visual acuity before the rings. We have only placed one inferior ring, and this is what we got after placing the ring. Was it not? We induced astigmatism in this case. We have 325 of astigmatism, but our vision was very good. We planned the same procedure, a corneal wave for treatment with an extra procedure, but removing the epithelial. And we can see here the summary of our result. We start with 0.1. We go after that 0.25 uncorrected, and we are uncorrected in 1. Sphere 2.5, 1.50, and cylinder the same. Improvement in all the parameters. We can have here the case. It's extremely impressive. This is the keratoconus after our ring, and 2 years after the treatment, 3 months result. The differential maps. In conclusion, LASIK and accelerated cross-linking in post-Keraring patients yields excellent results after 3 months. We need to prove the long-term stability to be confirmed that this technique really is worth it, but I believe it's a very good option in patients with previous intracorneal rings. Thank you very much.
Thank you, Maria Clara. Just one question, because you are going to leave. Do you use any special pattern to treat the refractive residual error, optical zone, any key, any secret, wavefront, topography assist, anything?
I already said, in all the patients I use corneal wave for treatments.
Just regular corneal wavefront?
No regular corneal wavefront. It is okay. Regular corneal wavefront. Yes, the one is in the Amaris with the arcade. Yes, but the optical zones depends of the patient.
Okay, but is you compare with other one, is it smaller or bigger? You compare with the standard 6 millimeter optical zone. What do you use, more small or big optical zone?
In the beginning, I was a little bit worried too, because the rings are there, but you see the ablations are not too much. In this case, when I see that I really need to go deep, I try to reduce the optical zone, because I don't want to be in the area of the rings. But if it's superficial, I don't mind if I'm even working in the top of the rings.
Okay, that means it's almost the same that always.
Yes, I'm not going to
tell me the truth,
6.
Tell me.
No, I'm telling you the truth.
Okay, Maria Clara. Very good. Thank you very much. Very interesting. Thank you. We're going to continue with Dr. Camonakel. He's going to speak about mode of action and indication of Keraring S5 and S6. When you want. Good.
Thank you. Good evening, everybody. I would like first to thank Mediphacos, especially Marcelo, for inviting me for this symposium. And today I will share with you my experience with SI5 and 6. So corneal remodeling using Keraring is today a confirmed treatment of non-complicated keratoconus. Basically, we have two models of Keraring, 5 and 6 millimeters, with different thickness and arc length. Everybody knows today that the general mechanism of action is corneal flattening, and with thicker segment and smaller diameter we have bigger effect. With shorter segment we have bigger astigmatism correction, and with the longer one we have bigger spherical correction. Despite this general knowledge, the exact topographic effects of all these ring models are still not well defined. For 2 years, I've been focusing on the action mode of different model of Keraring, and for this purpose, we perform a study of 420 eyes in which we analyze the action mode of each ring model using the topographic and elevation differential maps. And the important thing that we find out is that after observation of the topographic differential maps, we have noticed that the corneal flattening profile of each model is almost always reproducible independently from the ectasia shape. But the nuance is that the refractive value, the refractive amount of flattening is different, and it depends on corneal biomechanics of each cornea, of course. You have here 3 differential maps treated with Si5. We have 2 rings here, 1 ring and 1 ring, and you can observe that the flattening profile is reproducible. But maybe the amount, the value of flattening is different from case to case. You have here 3 differential maps treated with Si6, 2 rings, 1 ring here and 1 ring, and you can observe that flattening profile is reproducible. I will show you now a short video showing you a theoretical effect of Si5 and Si6 on spherical cornea. You have here a theoretical effect of Si6, and we can observe that we have 2 flattening spots here and here in the extremes of the ring, and in the area in between, that means the opposite axis, we have a slight steepening. And this can explain very well the strong astigmatism effect of Si6 and the reduced spherical one. Whereas with Si5, we have central flattening and peripheral flattening. The peripheral flattening is bigger than the central flattening, and that can explain the simultaneous effect on sphere and cylinder with Si5. Now, the effect with different arc length. You can see that with Si5 210 micron, we have a big surface, a large surface of flattening. That's why we have a big spherical effect. And you can observe that when we decrease the arc length of the ring, the flattening surface decrease, but we observe some astigmatism effect. And you can see here, for example, with 90 degrees, we have a flattening in this axis and the steepening in the opposite axis, and this explains the cylindrical effect of the short ring. Now, what about the refractive result? Regarding corneal flattening, we have with Si5 4.2 diopter, with Si6 just 2 diopter, but with astigmatism correction, we have more astigmatism correction with 6 millimeter ring compared to 5 millimeter ring for diopter. So we can conclude that Si6 provide us less central flattening and more astigmatism correction, and with Si5 more central flattening and less astigmatism correction compared to Si6. Now, in practice, our choice criteria of Si5 and 6 depend on distribution of keratometry, the shape, and the surface of ectasia. When you have like this topographic example, it's an early stage of keratoconus when the central keratometry is less than 52 diopter. In this case, we don't need to have a central flattening, but the desired effect is to treat an irregular astigmatism. So the ideal profile will be Si6 in these cases. When we have an advanced stage of keratoconus, like this example of topography, here we have a large surface of ectasia which reach the center of the cornea, and here the desired effect is a central corneal flattening and astigmatism correction. So in here the only choice will be Si5, which is the ideal profile here. Everybody knows that the good prognosis factor is keratometry, pachymetry, and best corrected visual acuity. But I believe today that there is another prognosis factor which is very, very important, who is ectasia shape. Because we know today that the results depend on ectasia shape, and the ideal today is to have the perfect matching between the flattening profile of the ring and the ectasia shape. This is an example of PMD with 5 diopter of cylinder. We have here the flattening profile of a Keraring, and we can observe here that with this flattening profile of the Si6 ring, we will have a perfect matching with this ectasia, and we have a perfect congruence between the ring and the ectasia. So in this case, we can predict that we will have a very, very good result. This is the post-op topography, which is very nice, and we have a post-op best corrected visual acuity 10/10. Some examples. Remember that the Keraring is an adjustable technique. This is an example of central keratoconus with -2 cylinder, -3 of sphere. We put here one Si6, and you can observe here a very poor flattening of the center with Si6. So we decide after 1 year to replace this Si6 by another one, which is Si5, and you can see that we have a better central flattening. An example with Si6, which make a very strong astigmatism effect, which is frequent with 2 rings. We have here an example with 6 diopter of cylinder. We put 2 rings, 2 Si6, 300 micron, 200 micron, and we have an overcorrection after 1 year, 6.5 diopter in the opposite axis. That means that the ring treated 12 diopter of cylinder. So we decide to remove 1 ring, and the final topography, 1 diopter of cylinder. Another example of advanced stage of keratoconus, stage 3, big surface of ectasia which reach the center, and here, as we said, the only choice is Si5 profile, and this is the post-op topography. The last example, keratoconus stage 2. Here we have an irregular astigmatism. The ectasia doesn't reach the center, so here we need just a peripheral flattening, so the ideal profile will be the Si6. Okay. Post-op topography. I would like to speak about a new project, which is a ring simulator.
You can, we are like 3 minutes late, but...
Okay, I will conclude.
Yeah.
This project is in process. It's a software of corneal topography using a database of topographic action of each Keraring model, which will simulate a real Keraring treatment. This is the basis of this ring simulator, which simulate the action in the case of a keratoconus of Si5 and at Si6. So we can compare the action of both rings so we can make a better choice. This is the interface of the software, pre-op topography, simulated topography. We can put one ring or two rings, which shows the diameter, the thickness, and the arc length. In conclusion, SI5 and 6 offer a large range of treatment. It's different philosophy of corneal remodeling, SI5 for more flattening, SI6 for more astigmatism correction. Today we have a multitude of forms of keratoconus. No one looks like the other. After having studied and filed the different corneal effects of the different Keraring models, it will now become easier to adapt to each keratoconus form the ideal ring profile. Thank you.
Thank you. Thank you very much, Kamon. We're going to invite to Juan Grandin to talk about personalized keratoconus treatment.
Okay, good afternoon. Thank you, Marcelo, for inviting me to be part of this evening, in this talk. I'm going to present what we do in Argentina in our clinic at Zaldivar Institute whenever we have a keratoconic patient. What did we used to have in the past? We only have the old players, as we call now, the contact lenses and the PKP were the only choices that we used to have. Now we have the new players that we can combine them and offer to improve the quality of patient with keratoconus, like Keratings, the cross-linking, the ICLs, and the femtosecond laser are the new players that came up to improve our quality in the keratoconic patients. So what do we do whenever we have a keratoconus form first? What is that? That is suspicious keratoconus. That is a patient that has abnormal topography without any clinical finding. So whenever we have this kind of patient, we do a frequent topography control. That is very important, even if they are in between the 20s and 40s. So every 6 months to do a topography control is very important. And obviously always treat the corneal surface diseases like dry eye, MGD, atopia, or whatever, because patients with keratoconus, they usually are allergic patients. So keep that in mind, that is very important. Whenever we have an initial keratoconus, what is that? That is a conus that we don't have loss of corrected distant visual acuity without surface irregularity, but the patient, we notice a difference in the progression in the astigmatism between, this is for instance 1 year in difference in the topography on the left and the right, and then there we do a cross-linking. What do we do whenever we have a keratoconus stage 1, 2, and 3? Without evidence of progression, but with loss of corrected distant visual acuity and with loss of surface regularity. So we do the Keratings and frequent topography control. This is a case, for instance, we are seeing there a surgery done with the intralace, the femtosecond laser that came up to made the surgery much easier than before with the manual technique. But to show how important is the topography control, in this case that I showed you before, this was done in 2005. We did the Keratings in this patient. After 6 months, he had an improvement in the cornea, and the patient never came back until 4 years after that. So we missed that follow-up, and the patient came with an advanced keratoconus. So this is for you to keep in mind that Keratings, they do not stop ectasia progression, so they only model the surface of the cornea. So if we have a keratoconus stage 1, 2, and 3, but with evidence of progression, with loss of corrected distant visual acuity, and with surface irregularity, like in this case from 1 year to the other year, with 1 year of difference, so in that case we do Keratings and simultaneous cross-linking. So this is to keep in mind. ICR, they only regularize corneal surface. We are seeking that is our main objective in these keratoconic patients. And the cross-linking, they improve biomechanical properties. So they are not complementary, they are not competing technologies, they are complementary techniques, okay? So what do we do whenever we have an advanced stage 4 keratoconus? If we don't have eardrops, we go to an intralace deep anterior laminar keratoplasty, and if we have eye drops, in most of the cases, we have to convert to a PK with the intralace also. But we always try to preserve the normal endothelium that keratoconic patients they usually have. And the clue, whenever we have a refractive error after the cross-linking or the ICL, when do we indicate an ICL in a keratoconic patient? 3 tips to keep in mind. First, we have to regularize corneal surface. If the patient has a keratoconus and we don't improve the regularity of that surface, the patient is going to have a bad quality of vision. Then we have to keep in mind that we have to stop that progression. If we're going to put an ICL, we want that to last forever, or at least until they develop a cataract. And always, whenever you have a correcting distant visual acuity of 20/40 or better. This is like an example. For instance, this patient of 25-year-old that has this topography with that corrected distant visual acuity with this high astigmatism myops. So after 1 year, we did the ICR and cross-linking, and after 1 year, this patient ends up with this refraction minus 425, 75 minus 1, 20/40. In this case, after 1 year of cross-linking, we indicate the ICL. We have realized it, everybody that has done sometimes any cross-linking, at the very beginning, they said that the cross-linking stopped working up to the first year. We have been realizing that you can still having changes after 3 or 4 years. So, but those changes are much less than at the very first year. So whenever we stop the progression of tachyphagia, then we send to Dr. Saldivar for the ICL. This is the case after the ICL, after 6 months. This case ended up with the 20/25 with that small refraction, 20/30 uncorrected. This is the second case with the initial PMD with that high astigmatism. So we did ICR and cross-linking. After 1 year, we sent for a toric ICL in this case, and we end up with this corrected visual acuity. So it's a very happy patient. This is a small video to show you how Dr. Saldivar used to implant the ICLs after we have rings. It's very important alignment in the toric ICLs is something that is the clue of this surgery, not only the technique but also the alignment. So it's very important to align this lens, because if you have any 5 degrees of rotation, you lose 15% of the efficacy of that ICL. So this was done, this is a previous one without the aquapore in the center, that now Dr. Saldivar is doing most of them with the aquapore, so you don't need anymore that iridectomy, but he usually performed that intraoperatorily. So to conclude, let's see. To conclude, the alignment is very important. This is a Scheimpflug image to see how nice they are, but the importance of the alignment. As the previous colleague showed, the difference in between the SI5 and SI6. The SI6 has a wider base that compensates the larger optical zone, and the triangular shape was changed to a scalene triangular shape. So whenever we plan an ICL or a phakic or pseudo-phakic ICL, we indicate a SI6 because you reduce the halos that sometimes the ICL patient also has. So the conclusion are that Keraring and cross-linking are excellent options for keratoconic patients. The earlier the stage of the keratoconus, the better the results with ICR and cross-linking, stage 1, 2, and some of the stage 3, never stage 4. Then in case with high refractive errors, we use toric ICL or ICLs, the regular ones, and we have reduced our needed for graft, notably in our practice with these new techniques. So, very important before ICL implantation, this is very important, so keep in mind, regularize first the corneal surface and stop the tissue progression, and then offer the ICL to that patient. Thank you very much.
Thank you, Juan. Thank you, Juan. Thank you very much, and it's my pleasure to introduce my dear friend Jerome Vriggen, whose talk is dealing with the surgical management of keratoconus rings and more. Okay, so Vriggen will come later. So is Dominique Petrini, early experience with the new Keraring 355.
Thank you, Jorge. Thank you, Marcelo, for your invitation. It's not a scientific presentation, but I had the opportunity, thanks to Marcelo, to implant the new one of the new Keraring, the 355, and Marcelo asked me to show you some cases. We have implanted the first 355 about 7 or 8 months ago. Okay, I have nothing to disclose. So you all know the objective of ESCRS implantation. It's first of all to regularize the surface, to improve and best corrected visual acuity, to reduce the refractive error, to reduce low and higher order optical aberration, improve contact lens tolerance, allow spectacle correction, stabilize the cornea, even if we see some cases of evolution of ectasia after ring implantation, and delay or avoid transplantation. Of course, as we have seen in the previous presentation, its cornea is unique and deserves an individual assessment. How do we select the ring that we implant? The selection is based, of course, on keratometry, astigmatism, refraction, asphericity, and a type of ectasia with variation according to ring thickness and arc. How to choose the diameter? We have seen the very nice presentation of Eikel Kamoun, but generally small diameters have a greater effect, and they are better for advanced stages of the disease, especially when you have high amounts of sphere, and larger diameter should be considered when mesopic pupil is large or when best corrected visual acuity is more than 0.6. And as we have seen also, when a second procedure is plain, of course ICL, but also a PRK, which is often, in our experience, which is frequently done after ring implantation. So the longer the ring, the more regular flattening on the corneal surface, and with long arc lengths, like for example 210 degrees, we treat mainly myopia, and with shorter rings, we mainly treat astigmatism, as we have shown regarding the effect on the opposite meridian. If we consider the arc length, the shorter the rings, the less effect on asphericity and keratometry, but high effect of cylinder. And for longer rings, we have an important effect on asphericity, and especially on Q values, on keratometry values, but almost no effect of cylinders. This is an example of quite regular astigmatism. This case of myopic astigmatism is treated by implanting short segments of 90 degrees with good effect of regularization. And on the opposite, in case of PMD, with a small cylinder in the center, a longer ring like the 210 degrees, specifically designed for PMD, will flatten the cornea without inducing a cylinder. In the new developments of Mediphacos, the new Keraring 355 allows to use Kerarings for a new specific type of keratoconus, which is nipple tip keratoconus. It's indicated for advanced central nipple tip, and the specificity of this ring is that it's very difficult to implant the ring in a tunnel. So we are obliged to realize a pocket with a femtosecond laser with a very small incision to implant the ring. So this is our first case. It was central keratoconus with a central pachymetry of more than 400 micron, poor uncorrected visual acuity, best corrected visual acuity of 0.6, and mainly myopia in the refraction, minus 7.5 diopter. So the pocket has already been done. It's a pocket of 8 millimeters, a small superior incision, and the ring is very easily placed through this incision, and the ring has to be centered in a second step on the center of the pupil. So it's the procedure is quite different. The pocket is made at a depth of 300 microns. And in the first case, the incision was a bit longer, and I decided to put a suture, which is not mandatory for this ring. Okay, this is a postoperative aspect of the ring. So this is another example of the, the same patient, the post-op, the uncorrected visual acuity went to 0.1 to 0.6. There's a gain of 1 line of best corrected visual acuity at 5 months, and with the patient almost plano. This is post-op topography of this patient. This is a differential map. You see in elevation, we have a 90 micron reduction in anterior elevation and a very high flattening effect on the cornea, up to 15 diopter, without inducing high amounts of astigmatism. This is the differential map on the pentacam of the same patient with this very wide area of flattening. Okay, this is the second eye of the patient. It was almost the same condition, central nipple tip, high amount of myopia, and 0.4 of best corrected visual acuity. You have seen already the patient, and here is the post-op. Uncorrected visual acuity went to very almost count fingers, 2.5. 2 lines more of best corrected visual acuity, and once again the patient has a plano refraction. This is a post-op, and this is a differential maps of the patient and pentacam. Okay, in conclusion, this new 355 ring is a new option in ring selection. It's more specifically designed for nipple tip keratoconus. There's a very high flattening effect, high reduction of corneal asphericity, and this once again improves the customization of the treatment. Thank you very much, and thank you, Marcelo.
Thank you, Dominique. Excellent presentation. And let's take now the presentation of Dr. Masen Sinjab from Syria, a new software for managing keratoconus.
Good evening. I'd like to thank Mediphacos for their kind invitation and giving me this opportunity to present my new software. Interest in ectatic corneal disorders is increasing day by day. As you know, there are a lot of management modalities. Some of them is non-interventional, like spectacles and contact lenses. Others are interventional, like corneal cross-linking, custom PRK, intracorneal rings, myoring, phakic IOLs, DALK, PALK, SALK, and we don't know what we would have in the future. Of course, those modalities depend to a great extent on parameters of the patient, including age, sex, progression, K readings, pachymetry, refractive error, topographic astigmatism, incorrect and best correct visual acuity, and corneal transparency. As you see, there is a lot of interrelations between those modalities. There is a big mess, like the buildings of this Congress. But in general, we can say the higher the Kmax, the more invasive the intervention will be. The thinner the cornea, the more invasive the intervention would be. The higher the refractive error, the more invasive the intervention would be. And the lower the corrected and uncorrected visual acuity, the more invasive the intervention would be. For this reason, I collected all the information about management of keratoconus under one umbrella, and I called that software Damascogram, SynJab data-based algorithm for managing keratoconus. I'll show you two examples in this software. Windows to input the data of the patient. We have 42 years old patient coming for his right eye. He is male. He has clear cornea and a stable case. His unaided distance visual acuity is counting finger, and the best corrected visual acuity is 0.7. The refractive error is -3 sphere, -4 cylinder. The Kmax is 58 diopters. The thinnest location is 459, and the topographic astigmatism is consistent with the manifest cylinder. And if we click on the management, the program will suggest some options. In this case, I'll read this. Advise using contact lenses in case of tolerance and observe the case in close follow-ups. Perform intracorneal ring segments implantation, observe the case. Or perform topography-guided PRK followed by same session corneal cross-linking. Or advise using glasses and observe the case. Now, the software arranges those options from the most favorable to the least favorable. Also, it provides a discussion of the case. This is another example. 19 years old female has a clear cornea in her left eye. Uncorrect visual acuity is counting finger. Best correct visual acuity 0.6. The case is still progressive. She has a very high refractive error, -8, -7. And the Kmax 62. The thinnest location is 440, and the topographic astigmatism is also consistent with the manifest astigmatism. We have such management modalities, including new modality like lamellar keratoplasty, new suggestions, lamellar keratoplasty, myoring, phakic IOL, and so on. Also, we have a discussion of the case here. Some of the features of the software, when the doctor by mistake skips to input some data, like here, no input of progressive or stable of the case, a warning will appear. Also, when the data are not logic, like in this case, very high refractive error, and the incorrect visual acuity is 0.5, a message will appear that there is no consistency between the refractive error and the incorrect visual acuity, advising the doctor or the optometrist to recheck the patient. General guidelines are provided in this software also, either for the combination between treatments or for each treatment, giving some topographical patterns in order to match the topographical patterns of the patient. Also, auto-saving of patient's information is provided in the software, giving the doctor all the previous patients. Features, I'll conclude. Features of the software. It can be connected to any topographer. It can be improved to give measurements and location and type of intracorneal rings, phakic IOL, and it is upgradable. Thank you very much.
Thank you. next speaker is going to be my friend Jorge Alio, and he's going to speak what do we have and what we need for keratoconus.
Thank you, Robert, and thank you to Mediphacos for inviting me to this very interesting symposium. And the topic is to make a critic overview about what we are doing with intracorneal segments and why we are in a stage in which we need to make a step forward to our better method. These are my relevant disclosures this year at this meeting, and we know by the experience and by literature and by our own practice that predictability of intracorneal rings and segments, either from the visual, refractive, or topographical perspective, is still an issue. We have, in spite of the many peer-reviewed reports, great variability of outcomes, and opinions still exist that are in controversy about many of the issues as well. And reports are usually based on a small series, and there is not a large group of patients in a systematic way approached from the diagnosis and the therapeutic perspective that really tell us what we are getting in terms of demography. So this is why some years ago we created the RETICS, which is an acronym of a network of clinical resources that we have created in Spain. And this is, we have created the Iberia Keratoconus database that gathers the information about keratoconus and intracorneal ring segments for the centers that you can see here in the image. And indeed, as far as we know, is the first network dealing with keratoconus that's been created so far. The aim of this database is to identify the variables involved in the characterization of keratoconus, involved in the diagnosis and grading of keratoconus, to study the outcomes obtained with novel therapeutic corneoplastic procedures in keratoconus, and third, to propose new therapeutic algorithms for the indication of intracorneal rings and segments and other methods in the correction of keratoconus in order to improve visual function, because what matters in this perspective is that the patient needs to be with a better vision at the end. So in the database we have 776 eyes of 507 patients up to June 2011. So this number is increased now, but we have taken all these cases up to this moment. These are the cases that are involved in this database as far as the results that I am reporting to you, and this is the base of the reports that I am going to inform to you that have been either published or in the way of being published by accepted publications. So we have developed, and I am avoiding a lot of analysis that we did, which are the variables involved in keratoconus in terms of vision. In other words, which are the factors in modern exams that we do in keratoconus that really have a relationship with the poor vision or the good vision of the patient. And the variables that are significantly related are the mean keratometry of the patient, the internal astigmatism, which is the difference between the anterior corneal surface and the total, the RMS, the Coma-like aberrations, root mean square, and the Q value at 8 millimeters. These values predicts how is the patient vision in keratoconus and will predict how is the outcome of everything that we put in order to improve the vision of these patients. And based on this data, in these variables, we have created a new classification that is not only about keratometry, is not only about pachymetry, is about vision, about how these different variables are related to the vision of the patient. Grade 1 keratoconus are those patients with up to more than 0.9 vision, which is really excellent, almost normal vision, with a keratometry which is less than 46.5, internal astigmatism less than 2.5, RMS of Coma-like aberrations less than 2.5, and a Q value at 8 millimeters less than minus 0.35. This is a grade 1 keratoconus, so in other words, you can have a keratoconus with a normal corneal thickness, but it's a keratoconus according with this information. About grade 2 is corrected for distance visual acuity and corrected for distance with glasses between 0.9 and 0.6, mean keratometry between 46.5 and 49, internal astigmatism between 2.5 and 3.70, Coma-like aberrations room in the square between 2.5 and 3.5 microns, and Q value between minus 0.35 and minus 0.75. Grade 3, corrected for vision between 0.6 and 0.4, keratometry between 49 and 53, internal astigmatism between 3.5 and 4.5, Coma-like aberrations between 3.5 and 4.5, and Q value between minus 0.75 and minus 1.10. These are very steep cases that could have, even that they are not frequent, even borderline pachymetry, but they are keratoconus. Grade 4 are corrected for visual acuity between 0.4 and 0.2. mean key-value 53 to 57, internal astigmatism between 4.5 and 5.5, coma-like aberrations between 4.5 and 5.5, and Q-value between minus 1.10 and minus 1.50. And we have a grade plus in which it's a grade 4, but with corneal opacities. These corneal opacities prevent an adequate analysis of corneal topography, and this is the grading system that we use. And this grading system has been published in Journal of Cataract Refractive Surgery, and you have access to this information in a much more larger scale, and indeed in a much better and better explained method. So this is a better approach because it has been developed from a large number of patients. For instance, Amsler's classification was based in 50 cases, and with different degrees of keratoconus. Second is based on the correlations with clinical and examination variables associated with Wilson function in keratoconus. Corneal aberrations are used in order to determine the degree of asymmetry from the corneal surface and the corneal optical quality. Never before, only in one paper that we did some years ago, we used corneal aberrations, Coma, precisely to characterize the degree of keratoconus. This is a much wider and much ambitious classifications, and the analysis of corneal sphericity at 80 millimeters will allow to estimate the geometry of the cornea for the first time in a significant area, not only at the central 3 millimeters, what happens to be with keratometry. And this is the main issues that we have, and this classification should allow us to provide a better therapeutic approach to the patient, taking into account the level of visual impairment that exists in each case and why this impairment has happened. This is the paper. Go to Journal of Cataract Refractive Surgery, and you will find how we built up this classification, how it's created, and how it is used at this moment. So, if we use this classification, do we gain knowledge in how to treat, or do we gain knowledge in how to classify? Let me tell you that we have used this classification in 563 eyes, in which we have an indication for intact, Keraring, and Myrin. So basically we have all types of devices that are implanted in the cornea. The cases were uniform indication in 304. That means that they follow the same indication with the same axis for the incision and other variables, and indeed they are reliable at this regard. Among this, we have one distinguished group, which is the 114 eyes that were operated by the same surgeon, with the same nomogram, all with femtosecond laser, with the same femtosecond parameters, and only with Keraring Ferrara. So this best case group is the excellent group to be compared with the others. And what happened in this best group, first of all, the outcomes were identical to the general group. It's amazing that even with the sophistication introduced by this the femtosecond technology, we got the same degrees of failure, and we have to see that this is the distribution of cases according with our classification. We have defined for the first time in the literature what is success. And for us, success is to gain one or more lines of S-corrected for distance visual acuity, to decrease 2 or more diopters in the spherical equivalent, to gain 1 or more lines of uncorrected distance visual acuity, to decrease in 1 micron at least of high-grade order aberrations, and to decrease in 1 micron coma-like aberrations. This is the definition of success, first time performed in the literature. And look what happened when we considered the classification and what we defined success in the best group. Uncorrected for distance visual acuity, as you see, we have that we improve in 100% of grade 1, 44% grade 2, 72% grade 3, 50% grade 4, 50% grade plus. That means that we have a refractive outcome that is favorable in grade 1 and less favorable with the progression of keratoconus. But look what happens when we take the best corrected for distance. We had success only in 17%, so only 17 improved vision, 56% grade 2, 47% grade 3, 77% grade 4, and grade plus 80% of the cases gain vision. That means that it behaves in the opposite to the refraction. We have a refractive procedure in early keratoconus. We have a therapeutic procedure that gains vision, promotes an improvement in vision, best corrected vision. And what about coma-like? We were happy in 50% of the cases improving high-grade order aberrations, only 17% in grade 2, 32% grade 3, grade 4, 13%, no case in grade plus improve the coma-like aberrations. So we have a disparity of the success as defined by the variables. What about failure? We define failure if we have lost 1 or more lines of S-corrected for distance vision, an increase in 2 or more diopters of spherical equivalent, loss of 1 or more lines of non-corrected for distance visual acuity, an increase in 1 micron root mean square of high-grade order aberrations, or 1 micron in coma-like aberration. What happens here? Failure never happened taking into consideration uncorrected vision in grade 1, 44% grade 2, 16% grade 3, 25% grade 4, and no case in grade plus. But if we consider best corrected for distant vision, a failure happened in 5% of grade 1, 34% in grade 2, 26% in grade 3, 22% in grade 4, and in no case of grade plus. So failure is behaving much more in favor of the grade plus and the severe cases of keratoconus. The other results were not as significant, and we had in the best case group about the same variables. Look here, when we are learning about the spherical equivalent, we had no significant difference in grade 1 in 71%. Simply talking, grade 1 did not benefit at all. Did neither improve nor worsen. Grade 2, 31%, 40% grade 3, 12% grade 4, and 71% grade plus. So this is the evidence that no significant benefit was obtained from the surgery in such a high number of patients. And if we take into consideration the root mean square of the Coma-like, 50%, 75%, 46%, 74%, and 100% of the cases did not obtain significant benefit. So think about what we have been showing, because we should not be happy. Just imagine that you are faced cataract surgery or the correction with excimer laser of myopia with this percentage. Nobody would have the surgery. We have a procedure that is effective, where we are not using properly, and of course we have to show the reason why. We have started to develop our own predictive model, and we have created this model about the topics that we have explained to you. And I'm not going to go into details, but these are the variables that are involved and predicted the outcome. Let me go a little bit further into this. We have worse outcome in high cylinders. We have worse outcome in very poor biomechanics. We have worse negative impact by very significantly high spherical aberration. We have primary coma as a factor that works and against the outcome, and probably the comatic axis should guide our procedure in some cases. And finally, we have the corneal guided aberration, excluding coma and spherical aberration, and indeed as an important factor in this coefficient. So these variables are involved, and we have never considered them as well related to the outcomes of the intracorneal rings and segment implantation. So in summary, and you can imagine that this is a very broad study, probably many questions will be left to you, but the message is we have a better classification that allows a much better and complete knowledge about the disease, and probably it will be in the benefit of the definition of how to treat. Intracorneal ring segments are unprecise in outcomes in spite of the present numbers that we have, and in spite of the anecdotal improvements that we get. Predictive models on large number of cases are the best method to reach a better indication, and indeed we have a conclusion. New rings and new segments models are necessary for keratoconus surgery. We should not be happy with what we do. We are happy because we had nothing to do before, but now we need to do a better job. New nomograms based on wider perspective of keratoconus disease, not only keratometry, but based on vision and the variables that influence the visual performance are mandatory, and predictive models for the visual outcomes of keratoconus need to be developed in order to guide our indication for this case. And I thank you very much for your kind attention.
Thank you, Professor Alio, for this excellent presentation, new approach, new classification, which is very helpful. And we invite now Dr. Vera Ramani from Malaysia, new Keraring vacuum system for mechanical dissection.
Thank you, Mr. Chairman, and thank you for Mediphacos and Professor Maslow to have invited me to give a talk. I was listening to all the speakers before, and I realized that we have gone far ahead with keratoconus management.
Nice place.
And I wish to inform that I have nothing to disclose and I have no financial interest. Okay. The new Keraring vacuum system for mechanical dissection. In my part of the world, we are still going on mechanical dissection because intralaser or any other femtosecond laser procedures is going to be expensive to the patient. And we are also in a time that many of our keratoconus patients have already undergone collagen cross-linking, and these patients come to us for further treatment for intracorneal rings. Okay. We have usually manual tunneling and femtosecond laser tunneling, which is the in thing these days, but it is expensive for my patients. And in manual tunneling, it is much cheaper to perform but we have problems with patients who have already had cross-linking done. And when we are doing the procedure, it's really difficult to insert the rings. And the depth of tunneling may also vary depending on the cooperation of the patient, because the eyeball will keep on moving. Now this is the instrument set that we use, and the most important part in this set of instrument is a diamond ring and also the tunnelizers. The previous tunnelizers were huge, and we had 2 sizes, and it was difficult to handle, especially when you want to record your surgery under the microscope. While you're on the microscope, sometimes we do not even get a good view, and the eyeball is so wobbly that it goes out of the range of the camera itself. And in manual tunneling, sometimes we can have complications, such as extrusion of the ring, or you could have placed it so superficially that after a few days the epithelium just erodes away and the ring gets exposed. Okay. Of course, with manual tunneling, so much of manipulation, we used to see a lot of exudates along the ring, and I used to wonder whether it was an infection or just some exudates. So I like to show you the manual tunneling video. Of course, like all cases, we mark the corneal surface. And this is a patient that I have done on the nasal side, a conventional tunneling, and on the temporal side with a new system. Now, I have to hold the eyeball with an instrument, and the patient is under local anesthetic, and you can see that the eye keeps on moving. And because we are holding the eye in various areas, and the conjunctiva gets sometimes traumatized, and next day the patient has got a big subconjunctival hemorrhage, which is quite annoying to the patient. Now, it's so much of trouble to do the tunneling, and this patient has not even had a collagen cross-linking. Okay. Now, using a femtosecond laser can be very, very expensive to the patient, and wound of entry sometimes may require suturing to prevent extrusion. Now, in the vacuum tunneling system, which was recently introduced by Professor Maslow to me, is a very, very simple piece of equipment. You've got a vacuum ring, which actually fits most of the eyeballs. In my country, we have a lot of Chinese patients with very, very small eye, and we do not lose very much of the suction with this ring. And then the tunnelizers have also changed. No more those bulky tunnelizers, but simple tunnelizers which you can hold very well. And this is a very simple apparatus to handle. Again, you are doing everything under local anesthetic. Patient is also not uncomfortable. The pupil doesn't get dilated, and there was not much of pressure. Okay, this is the same patient. On the nasal side, I was trying to do the manual tunneling, and in this side, on the temporal side, I have used the vacuum ring. You can see that the vacuum handle is useful for holding the eyeball, and it is so much easier to perform the tunneling. The only problem that can happen is if there is too much of pressure, there can be an accidental perforation. Like this patient, you can see that the site of the ring is higher, but there was endothelial perforation. But still, once we realized that there was a give when we were inserting the ring, we took it out the next day and replaced it at a different plane, and it went on fine. Okay, these are the newer tunnelizers, which are much slimmer and easier to picture it. And these are the instruments again. Now, there are other vacuum tunneling systems in the market, I think, and these are all quite bulky, and it's also used by other companies, but not popular in Asia yet. And therefore, doing this conventional and vacuum tunneling, is there a difference in our pre-op or post-op results? There's not much of a difference, except that when we use the vacuum tunnelizers, the post-operative results were a little bit better than the ones where we use the conventional tunneling. And even the astigmatism was not much of a difference, and therefore it did not really affect the placement of the rings or the changes in the astigmatism, and mean SIMK is not so different either. Therefore, the advantage of vacuum tunneling shows that early data in my results show that it has got slightly better clinical outcomes compared to the conventional tunneling because the patient recovers faster, better vision, and there's a little bit of better corneal shaping. Differences are very minor, but the results are consistent, especially when we are doing the surgery, and there is a remarkable advantage when in the intraoperative period, and it's much of an easier tunneling procedure to do. Maybe by next meeting, I'll be able to present my results with a femtosecond tunneling. Thank you very much.
Thank you, Dr. Romani, for this interesting presentation. The next speaker is our friend and colleague, Luis Cadarso, Coma versus cylinder axis for Keraring positioning.
Thanks, Mr. Chairman. It's really a pleasure to be part of the faculty. And I would like to talk about Coma versus astigmatism for Keraring positioning. Many years ago, Paulo Ferrara told us that the best way to implant the rings were the steep meridian on the cornea, and then decide whether to put one or two rings, usually the thicker one in the more, let's say, red part of the topography. On the other hand, Joseph Collin shows that the best way to implant the rings was to put one or two, usually the thicker, in the inferior part, to work like a breast lifter, like a bra, and recenter the cone in the center of the cornea. I think that how they report good results with two different strategies. And I think one of the reasons is that at that time they were relying on the axial maps that are a very, very simple way to examine the cornea. And with new technology, we are able to look at more specific and more detailed facts of the keratoconus cornea, especially corneal aberrometry. Now we have instruments that allow us to see the corneal aberrations, and in this case you can see that there is a very good matching of the keratometric astigmatism, the aberrometric astigmatism, but you see here that the Coma aberration is completely different axis. I will skip that slides because I'm trying to explain what is meridian and what is axis. Sometimes there is a confusion between meridian and axis, and when we talk about Coma, we would like to have some reference to talk about. So I mean with Coma meridian, because in Coma you cannot talk about axis, and it's better to talk about meridians. And we have the Coma meridian is where the radial profile shows the maximum amplitude. But for analogy, we may use the meridian where is the minimum amplitude as the Coma axis. So I will refer that as a Coma axis. Another point I think we should mention is that it depends how you look at the aberrations that make a big difference. If you use a pentagram, the usual way to look at this is a wavefront error, and you see here in the upper bar. But if you use another scale, like you can see this same information like OPD, that is exactly the same information but with a changed sign. So I propose to use the OPD because it's more easy to understand where the conus is. The main aberrations in keratoconus are vertical coma, trefoil, and secondary astigmatism. And Dr. Aliot told us his classification based on one of the parameters is coma aberration. I think more and more coma is going to take place. Is relevant, the coma aberration? And I would say definitely yes. And if you look at the patient with keratoconus and you try to take the visual acuity, the most frequent movement they do is lift the chin in order to see better. And this is because they, with the inferior lid, they, close the more deformed area of the cornea. So another clinical fact is that when you get very bad best corrected visual acuity, usually high order aberrations should be taken in account. There are values for coma aberration in normal population. And I would like to show you what was my experience analyzing the difference between the keratometric astigmatism and coma aberration. And you see that not always they match. Sometimes they do not match. And I think this is have some prognostic conclusions. This is a case where, the astigmatism and the coma match. And if you put there is no doubt that you should put the ring on this side, and you see that how the coma and the astigmatism gets reduced. In this case, you see here the keratometric astigmatism and the coma do not match. And in this case, the surgeon decided to put the ring on this side. And what do you see? This is a significant reduction on the astigmatism as the ring was implanted on the astigmatic steep meridian. But you see here an increase in coma and change in axis, and the patient improved in vision, but the quality of vision was very bad with increased glare, and finally the patient should have the ring removed because it was intolerant. So I think sometimes you have to analyze more than astigmatism. You have to analyze coma, and in some cases it's better to treat the coma even if you have to increase the astigmatism, because you can treat astigmatism, irregular astigmatism, in a more different ways. We presented some results using intracorneal rings based on the coma axis in as electronic poster in the ESCRS 2006, and we could demonstrate some kind of effect on the high order aberrations implanting the rings. So if there is agreement between both, it's easy to decide, and we expect good outcomes using the rings. But if they do not match, there is some disagreement. You have to choose between one or the other, and or perhaps in the future we will have some custom designs to improve both at the same time. Here you see how the coma aberration gets affected after the ring implantation, and you see here some effect from the epithelium that regress the effect of the rings. Ideally, the effect of the ring should look for overcorrection of the coma, and epithelium finally get to the point of ideal correction. I would like to present to you the software that help us to decide whether to use the astigmatism axis or the coma axis, and tell us the pachymetry all around the tunnel, the possible tunnel. So it's very helpful to do that. So finally, I would like to tell you that we should consider implanting the ring not only on the astigmatism steep meridian, but also in the coma axis, because will improve quality of vision. In order to correct myopia and astigmatism may be corrected by other means. Thank you very much.
Thank you, Luis, for this very interesting presentation. Now the last presentation today, or the one before the last, yes, it's the one before the last, is Francisco Sanchez, Keraring, followed by phakic IOL for keratoconus and high myopia.
Thank you, George, for the introduction. And let me tell you that 10 years ago, when we started implanting Kerarings and other kind of intra-ring segments, our professors from that time, they used to tell us that rings were not a refractive procedure. But let me tell you that during the last years, when we used the corneal rings in combination with the femtoseconds laser channel, and besides, with the option of implanting a phakic IOL, probably this procedure today is a refractive procedure. So what I'm going to talk during this presentation is the sequential intra-ring segment implantation and the options to use an anterior chamber IOL for the treatment of keratoconus and high myopia. As you know, there is a concept, which is the corneoplastic concept, where we as surgeons have the option to remodel the cornea without using any invasive procedures such as penetrating keratoplasty and lamellar transplant. And the aim of these procedures are to improve the optics, topography, optic performance, and of course, we need to reduce the refraction as well. When I was in my corneal fellowship 20 years ago with Roger Steiner at Tufts New England Medical Center, besides the diagnosis of keratoctasia with the early stages of topography analysis, we only have, as many others said, contact lenses, adaptation, spectacles, and we need to wait until the penetrating keratoplasty with the corneal scarring of the patients to perform a complete transplant. But today we have many options. As you mentioned before, the cross-linking, intrastromal rings, topo-guided photoablation, bulk, and phakic IOLs. So today I think the combination of intrastromal rings with phakic IOLs can give us the option of the refractive treatment in patients with keratoconus. This is our flow chart, therapy decision 3, and this is probably what we were using today in our clinic in Mexico. If we have a no-progression and an acceptable visual acuity with no scar, spectacles and contact lenses still are useful for the treatment of these patients. If we have an unacceptable visual acuity and scarring, definitely the way to go is DALC with the standard treatment, or DAL assisted with femtosecond zigzag technology with the interlace. If we have mild progression and acceptable visual acuity, probably the cross-linking is the best way to go. However, if we have progression, unacceptable visual acuity, no scarring in the central cornea, and irregular astigmatism, contact lenses, intracorneal rings, intraocular lenses, phakic intraocular lenses, or laser, topo-guided laser ablations, alone or in combination in between are good options not only to perform the corneoplastic effect in this very diseased cornea, we can also try to treat the refractive component that, as we know, is important in patients with keratoconus. Probably in the past, the pioneers in using the intracorneal rings, we knew that when we were using, for example, other kind of rings, such as the Intacs, and we face this into a patient with a -10 of a spherical component, we were only able to or capable to treat 2 diopters, and that patients felt very, very unhappy because residual myopia was -8 or -7. We have new technologies or new techniques for cornea transplantations, and there is no doubt that they offer better approach to these patients and less risk. We have the big bubble technique, but however, these patients usually takes, even if we use the big bubble, they take more than 18 months to recover, and usually the refractive error is not guaranteed. These patients will require probably a laser procedure, either a PRK or LASIK, and then we have this option to combine a ring and a phakic IOL of your choice. Can be an ICL, toric ICL, or in this presentation I will show you the results of 10 patients that receive in combination first the intracorneal ring and 6 months later the cachette anterior chamber intraocular lens. And these patients recover very, very, very fast, as you see, usually in a period of 6 months of time. This is an example of a patient that had that received 90 degrees intracorneal segments, 300 microns thickness, and 6 months after, he received an acrosoft cachette. Preparative best corrected visual acuity was -8, axis 45, 20/50 best corrected visual acuity, and after the procedure, 12 months after the procedure, first the rings to correct the stigmatism, and 6 months later, the cachette IOL to correct the spherical component of the refraction, and we achieved 12 months later, +1, -1, axis 50 for best corrected visual acuity of 20/40. This communication from Star Surgical, from a case that have the same situation. He had a compound myopic astigmatism. This patient received the intracorneal segments, and several months later, an ICL was implanted in order to improve the refractive component of this refraction in a patient with keratoconus, and the patient achieved 100% satisfaction. Which are the clinical pairs when we calculate the IOL for these difficult patients? Well, we suggest to use the same parameters workup and calculation as in the standard ICL implantation. However, when refraction in keratoconus eyes is difficult, we suggest to calculate with the subjective refraction, which provide the best vision for the patients. When the refraction and keratometry cylinder agreement, we suggest to implant the toric ICL only in those patients where the axis of the astigmatism amount of the refractive and keratoconic cylinder are agreed, and we indicate an spherical ICL in those cases where there is no agreement and only the spherical myopia value is high compared with the astigmatism value. Of course, patients need to have more than 3 millimeters of anterior chamber keratometry. The best cases, of course, are when we use this procedure for patients under 55 diopters in order to reduce, because if not, we will reduce the predictability in terms of calculation. Well, I suggest you to take a look to this paper that was published last year, November last year, and I think Pepe Alfonso was the first brave ophthalmologist in the world to say or to conclude that sequential intracorneal ring segments and a posterior chamberal implantation plus corneal relaxing incision provide good visual and refractive outcomes, indicated that this is a predictable procedure for refractive correction of keratoconus. So this is the first time that an ophthalmologist is so brave that he published in the most prestigious journal of our specialty, saying that we are able to treat keratoconus as a refractive procedure when we combine these techniques. I have experience using the combination of the intracorneal rings and the ICL. What we suggest is first to perform the corneal rings, and whenever we feel we have a stable topographic and refractive result, and this is probably achieved 6 months after the procedure, you can go ahead and use the anterior chamber or posterior chamber phakic IOL of your choice in order to treat the refractive residual the residual refraction of these patients. So in this small research or study that we use the sequential Keraring implantation and acrosoft cachette for keratoconus treatment, we use inclusion criteria, eyes with keratoconus that has sequential eyes intracorneal ring segments implantation and anterior chamber phakic intraocular implantation using the cachette IOL. The inclusion criteria all were keratoconus, contact lens interlens, and clear cornea. Maximum keratometry suggested was 55, and minimum keratometry reading and more than 40 diopters, and minimum corneal thickness more than 400. And this is the SI5 technique. You see the introlace. There is no doubt. My parameters is 80% of the corneal thickness in the area of implantation. I really like to have very tight channels. If we really want to achieve the corneoplasty concept, if we really want to accomplish it, I really suggest to use tight channels. So I use 4/8, 5/3 inner diameter, outer diameter. The the entry cut length in between 0.90 and 1 millimeter of extension, and as many have mentioned, I use the steepest meridian to complete the dissection. As you know, the interlace provides us in 5 seconds dissection of the circle or the ring dissection you just saw using this handheld keratometer, the regular shape in the cornea, and this is an asymmetric technique using 160 one side 90 degree segment in the other area of the cornea, and this is the control image that they after. For those of you who are afraid,
Francisco, please, 1 minute more.
For those of you who are afraid about the night disturbances, I suggest 6068 using the interlace for your IS6 segments. If you are afraid about night vision disturbances, I only will take 1 minute. And this is the video of this technique. We are using here 6 millimeters inner diameter, 6.8 outer diameter for implanting this larger optical zone intracorneal segments. It takes a little bit more, only 8 seconds, and this is a dissection created by the interlace. And here, this is one of the examples where we have a compound myopic astigmatism. When we have high spherical component, high astigmatic component, we treat first the astigmatism with the rings, and later on we use the segments. This is a video where we combine the rings to treat the astigmatism, and 6 months later, we use the cachette intraocular lens anterior chamber phakic IOL for the treatment of the spherical component of refraction. So combining the use of femtoseconds, rings and segments, we are able to reduce the spherical component in this 10 series of patients. This is an example, of course, even though that the outer refracting is the best way to analyze. In this patient, he has -20, -4, and we were able to reduce to -0.5, -3/4 of cylinder for a good result and achievement of the corneoplastic. Not only the corneoplastic concept, we were able to treat the refractive component of this difficult patient. So in conclusion, sequential Keraring and anterior chamber phakic IOL provided good visual and refractive outlook, indicated that it's a predictable procedure for refractive correction and keratoconus. So during the last 10 years, the therapy of keratectasia has undergone the change in paradigms. PKP or DAC is appropriate only for advanced cases with scarring, and definitely the stromal wrist and phakic IOLs are a good option to treat not only the corneoplasty for these patients, we are able to treat the refractive component of this disease. For your attention, thank you so much.
Thank you very much, Francisco. Now, last but not least, our dear friend, Dr. Jerome Briggen, will close the session with the surgical management of keratoconus, rings, and more. We shall have time for a brief discussion afterwards, so please prepare your questions. As far as the presentations have been very diverse, and it's really interesting.
Okay. First, want to thank Marcelo Soares for having invited me to this meeting. He probably invited me because I'm the organizer of the yearly Keratoconus expert meeting. We talk on surgical visual revalidation techniques, and in this meeting, 40 or 50 of the top world experts are gathering together, trying to come forward with strategies that will be useful to less experienced surgeons. And so my talk is called Rings and More, because, and I was pleased to see some images of other techniques than just rings, implantation of ICLs or cachet intraocular lenses. So I hope I won't repeat what has been said by other surgeons before, but as you know, keratoconus cross-linking has changed a lot of things, but it's still a deceiving procedure because it only stabilizes the situation. And we have a lot of patients who want more, especially those patients who have stable keratoconus after cross-linking or because they are older, and specifically patients with contact lens intolerance. And they want to be functional again, and this is one of the reason that in my strategy I always try to aim for near emmetropia. Of course, the expectations of the patients have to be realistic. They have to be aware that with contact lenses the visual quality will always be better than with any other surgical procedure. So I'm implanting artisan lenses since 1991. I have been involved through Theo Seiler very early with topography-guided surface ablations and implanting Keraring specifically since 2010. What procedure are we going to choose to visually rehabilitate our patients? Well, the decision is based on parameters like spherical equivalent, astigmatism, corneal thickness, age of the patients, and so on. Don't forget, we always try to reach near emmetropia. So what are the advantages, disadvantages, and side effects of the different techniques? Topography-guided surface ablation always have to go together with cross-linking. The cross-linking has to be performed before or together with the ablation. It's a non-reversible technique. The tissue that has been ablated is not going to come back. The advantage is that the cone is recentered and that the cornea becomes more regular. Up to now, there were recommendations not to ablate more than 50 microns of tissue, but last Friday, during the last expert meeting, some surgeons came forward to change that parameter and suggest us to ablate much more tissue in such a way that you always leave a minimal of 300 micron of stroma. If you keep, of course, the ablation to 50 micron, you can't take a lot of, you can't correct a lot of ametropia, and often the refractive error will be corrected incompletely. Phakic intraocular lenses, the question is whether you need cross-linking or not. You very probably need it in progressive keratoconus and in young patients. The advantage of that technique is that it is theoretically reversible. You can take away the lens. The disadvantage is that the cornea remains unchanged. You can correct higher myopias and higher astigmatism up to -7.5 diopter, and you have all the disadvantages of an intraocular technique, and what we fear the most is, of course, infections. Intracorneal ring segments, cross-linking possibly cannot be needed. Some surgeons claim that rings in themselves have a stabilizing effect on the conus, but in my politics I still, especially in younger patients and in documented progression, I still do cross-linking first. It's again a theoretically reversible technique. The conus is recentered, the cornea becomes more regular. We can as well correct higher myopias and astigmatism, and in the follow-up, what surprised me is that a lot of patients complained about halos, but these halos were not always disturbing. So let's look to some results. These are data from 2 years ago. Meanwhile, I have much more patients, but the data I have collected at that time included 19 eyes of patients where I performed topography-guided PRK. In 12 eyes, the cross-linking was combined with the ablation. These are some of the results we can obtain. In general, I apply that technique in moderate keratoconuses or first keratoconuses, and in this patient, the conus has been recentered and the astigmatism of the patient has been corrected, and the patient is satisfied. Let's conclude. In my eyes, you have with this technique more side effects, possibly because the treated eye is more in competition with the better non-treated eye. I have slightly lower satisfaction rates than with other techniques, and the possibility of retreatment is limited because often we don't have enough tissue available. This explains this graph where the mean satisfaction is only at 65%, with some patients really disappointed. In intraocular lenses, I performed 14 implantations of phakic intraocular lenses in keratoconus patients, some artisan, some artiflex. We can treat with a quite high predictability the refractive error. Here in this case, the patient had a cross-linking first, which increased the astigmatism, and in the second stage, the patient had a phakic intraocular lens with a good uncorrected visual acuity. In this patient, we have an even higher myopia with some astigmatism, excellent visual results. Conclusion, the cornea remains untouched, but we have, on the contrary, a high predictability of our refractive outcomes, which results in a higher independence towards glasses or contact lenses. Surprisingly, patients nearly do not complain about side effects, possibly because they are used to see that badly, and we have higher satisfaction rates, which is again seen in this graph with 82.5% of satisfied patients. I have implanted 14 intracorneal rings in 13 patients. With in 4 patients, I introduced 2 segments. I chose for Keraring because of its triangular shape, which gives us a more refractive effect, and because the triangular shape gives as well less reflections. You know that we have several models, several optical zones, several lengths, and so on. I have no experience with Ferrara rings and Intacs. Why did I choose for Keraring? Well, because I had an excellent service. You sent your data to Brazil, to Marcelo, with refraction topographies. They come back with a surgical plan. With the implants, you have to use the depth of the tunnels, the length of the tunnels, and to make these tunnels, I use a Zimmer LDV femtosecond laser that allows us to make the tunnels at a precise depth, precise position, precise length, and this should result in a higher predictability. Again, they give us an excellent advice. Once I've got a schedule from Keraring, they sent me back what data I should introduce into the laser. That makes things very easy. You need a special handpiece, which is the lamellar corneal surgery handpiece, which has an integrated top view camera, so you can see the applanated area. You have to mark the visual axis, of course. You can, the ablation, the handpiece in itself has a fixed focus of 500 micrometers, but you can vary the depth of the tunnels by sticking a foil of a different thickness on the window of the laser head, and this gives you the predictability in the depth of the tunnels. You can as well adjust the center of the trajectory manually by playing with these arrows. We have some excellent results, like in this patient where I was able to correct a high myopia and astigmatism. In some cases, we still have some residual astigmatism. As you may see, sometimes after implantation of rings, it takes some time before you obtain a stable result. This explains why in the beginning you had 4 diopters astigmatism, then later on 1.5, and even later on a 2.5 astigmatism. In some other patients, I had unpredictable results with no change in uncorrected visual acuity. And in one patient, I even had a worsening of the myopia. So the problem of rings in my hands, at least, I'm possibly not the most experienced surgeon. I have a problem of predictability of the refractive outcome. So conclusion, we recenter the cornea, we regularize the cornea, we have less near emetropia, we have halos, but not that disturbing, and satisfaction rates of approximately 66%. So with all of these techniques, we have encouraging results, as long as we have told the patient that their expectations should be realistic. Contact lenses give better results. I chose for topography-guided PRK in low spherical equivalent. The cross-linking is, of course, mandatory, and I use it as well in a second stage as fine-tuning tool. Phakic intraocular lenses are chosen in centered conuses with a good BCVA, and in higher myopia and astigmatism, and rings in decentered conuses with a slightly lower BCVA. Again, we can correct higher myopias and higher astigmatism. You can as well combine all these techniques, as the previous surgeon has showed us. So, phakic intraocular lenses in higher ametropias, topography-guided PRK for lower ametropias or for fine-tuning, and rings, well, especially when the conus is decentered, the BCVA is less good, but less predictable results. In fact, in our expert meeting, we can really see that you have 2 different schools, the ring school and the topography-guided PRK school. And on top of that, none of the experts are using phakic intraocular lenses. Ideally, both should have listened should listen to each other, or at least build up experience with both techniques. And when I asked to all of the surgeons present, only 4 or 5 of the 30 present combine all the three techniques. So possibly we have to learn a lot of a lot from each other, and we should be able to play with these techniques and hopefully come to better results later on. Thank you.
Thank you very much. And well, it's very late. You are really acknowledged to stay here for so long. And is there any question for any of the speakers that are still here? Dr. Briggen will be happy. He has provided an excellent keynote to finish the meeting because he has made a very comprehensive and didactic presentation, and I want to thank you for that. Any question, Dr. Briggen or any of the speakers? Okay, so let me ask one question to Dr. Briggen, just to close it. Are you happy with the outcomes? Because you were not here, but you listened to one of our presentations, and we have demonstrated that the rate of success of rings or segments is 50%. If we define success as gaining vision, decreasing aberrations, decreasing refraction, so we are not dealing with an optimal result. We have a long way, and for sure the future is very promising, but what we have at this moment is medium. It's better than nothing, but it's not as good as we think. We are encouraged because we're dealing with an untreatable disease in which we are getting good outcomes. But if you look at the outcomes in high volumes of series, they are not as good as we expect. So my question to you, are you happy with what you do?
Yes, I'm very happy, but I always tell that all the techniques we apply are called surgical visual revalidation procedures and not visual corrective procedures. And this has to be clear into the mind of the patients. On top of that, all these patients have tried a lot of things. They went through a long road, and often they are, if the result is not optimal in our eyes, they are quite satisfied. This you can see in the satisfaction rates. We have to be aware that we have no miracle solution for keratoconus, and even between experts, you have such different roads that we have to learn a lot of things about keratoconus still and about the revalidation techniques.
Mm-hmm. Well, I think that the happiness for a cancer patient is not to die, but this is not happiness. We have, at this moment, a long way to improve our outcomes, and we are happy because we are improving some of our patients, but not more than 50%, and that means that we have a lot to learn in the way in which we have to really avoid corneal graft and to improve vision in keratoconus. So we have one question. Okay, the question is there any connection between keratoconus and allergy? The answer is yes, because ocular surface inflammation is one of the reasons of activation of the metalloprotease cascade, and Robin is the second. So patients with allergy, by the allergy itself, have an activation of metalloproteases, and this chronic inflammation in low degrees is one of the reasons of keratoconus. The second is these patients are rubbing the eye. So yes, there's a connection in two ways. Thank you. Any other question? Yeah, no more? Suggestions? Okay, as a summary, I could say that this symposium has been important. We know a lot of issues that are at this moment being addressed in keratoconus. We have rings, we have collagen cross-linking, we have the combination with excimer laser surgery, we have other methods, and others will be evolving. For sure, this is a starting point for a better life for keratoconus, and the next step is to study how to do it better, how to improve the quality of life. We need to measure the quality of life in these patients. Possibly we shall have the answer in many of our doubts at this moment about how to treat in those procedures that are much more improving the vision quality and the quality of life of our patients. So I want to thank Mediphacos for this opportunity to have this symposium, for this moderation, all the speakers and all the attendees for keeping us until so long. It is 8:30 and still we are here. Thank you very much, and the session is closed.